Tuberculosis lymphadenitis. It is a common condition in Pakistan, mostly affecting cervical lymph nodes. The majority of the patients are children and young adults. The tonsillar, jugulogastric lymph node is often the first to become enlarged. It is followed by widespread cervical lymphadenitis, as well as the involvement of other groups of lymph nodes. In untreated cases, the tuberculous lymph nodes pass through the following stages. Stage 1: solid enlargement of lymph nodes, which are matted together due to periodontitis. Stage 2: the lymph nodes break down due to caseation necrosis and liquid material leaks through the capsule of lymph nodes. Thus, cold abscess forms and remains confined deep to deep cervical fascia. If the abscess is large, fluctuation may be elicited. Stage 3: after a few weeks, deep cervical fascia is eroded and cold abscess enters the subcutaneous plane. It is called a collar stud abscess due to its shape. It makes a prominent subcutaneous swelling, which is fluctuant. Careful palpation may reveal a matted lymph node mass deep in the abscess. Stage 4: if still left untreated, the abscess enlarges and the overlying skin becomes reddened. It finally bursts and results in a discharging sinus. If all the pus and necrotic material is expelled, the sinus might heal. Such cases present with multiple scars due to healed sinuses, along with matted lymph nodes in the neck. Investigations. Complete CBC shows anemia and lymphocytosis. ESR is raised. MON2 intradermal test is positive. ELISA test is a serological test for tuberculosis and may be positive. Sputum examination may show gram-positive tubercular bacilli. Chest X-ray may show fibrocavitatory lesion, usually in right upper lobe, calcification, pleural effusion. FENAC of enlarged cervical lymph node shows tuberculosis in 90% cases. Lymph node biopsy shows caseating granulomas. There is area of central caseation surrounded by epithelioid cells, Langerhans giant cells, and lymphocytes. Aspiration of cold abscess. It may be positive for acid-fast bacilli. However, the aspirated PEOS may be tested for PCR, polymerase chain reaction. It is highly sensitive test since it can pick up even few DNA strands of tubercular bacilli. Wedge biopsy of tubercular sinus might show caseating granulomas. PEOS culture and sensitivity. Growth of bacteria takes 6 weeks, and they are seen with Ziehl-Neelsen stain. By BACTAC method, positive culture can be obtained in 2 weeks' time. Treatment. The mainstay of treatment is anti-tubercular chemotherapy, box 4.4. Combination chemotherapy using multiple drugs is given for 6 months to treat the infection and to prevent the development of resistance. Genitourinary and bone tuberculosis require treatment for 9 months to 1 year. 4 drugs, INH, rifampicin, pyrazinamide, and ethambutol, HR, ZE, are given for 2 months, followed by 2 drugs, INH and rifampicin, HR, for another 4 months. Side effects, box 4.5. INH causes peripheral neuritis, hence, tablet pyridoxine, 10 mg OD should be given along with INH. Rifampicin is hepatotoxic. It also causes reddish discoloration of urine and body fluids, saliva, sweat, etc. Pyrazinamide is also hepatotoxic. It should be avoided in patients of gout. Ethambutol causes visual impairment due to retrobulbar neuritis. Other measures, high protein diet and vitamin supplementation, multiple drug resistance, MDR, tuberculosis causes. Inadequate treatment or noncompliance with drug treatment, infection in immunocompromised patients, e.g. AIDS patients, infection with atypical mycobacteria, e.g. Mycobacterium kansasi, M. avium, M. fortuitum. Such cases show no response with routine antitubercular chemotherapy. A culture of tubercular material, e.g. cold abscess, is required for the identification of specific species, and the treatment is given according to the drug sensitivity report. The treatment may last for 2 years. The second line of chemotherapy for such. The dosages are as follows. INH 300 mg day, 6 mg kg. Rifampicin 400 600 mg day, 10 mg kg. Pyrazinamide 500 mg day, 30 mg. Directly observed treatment, DOT, for tuberculosis. The failure to take medication as prescribed is a universal phenomenon, especially in chronic diseases. This is responsible for the development of multi-drug resistant tuberculosis. Given this, a revised National Tuberculosis Control Program has incorporated the concept of direct observation of treatment, DOT. It means that every dose is administered under direct observation. The treatment observer ensures that medicines are taken at the correct intervals and in the correct dosage. It has the benefit of a high cure rate and a dramatic reduction in the development of drug resistance. Also, adverse effects are quickly identified and treated accordingly. Treatment of cold abscess. Small cold abscess mostly resolves with anti-tubercular chemotherapy. Large-sized cold abscess, not responding to drugs, needs aspiration. The aspiration should be done with a wide-bore needle, 1820G, and it should be anti-gravity or non-dependent aspiration to prevent the formation of persistent sinuses along the needle track. Sometimes, repeated aspirations are required at intervals of 1-2 weeks. Surgical treatment. If there is a persistent cervical sinus with an underlying lymph node mass which fails to resolve with drug treatment, it needs surgical excision. Due to periodontitis and fibrosis, the lymph nodes in the neck may be adherent to the adjoining internal jugular vein, carotid artery, and vagus nerve. Hence, liberal incision and wide exposure under general anesthesia is necessary for dissecting lymph node mass from these vital structures. The excised tissue should be subjected to histopathology and culture sensitivity.